everyone. Thank you for joining us today for our educational webinar on the clinical and operational efficiency with hybrid operating room, sponsored by Baxter. We have a stellar lineup of speakers for today's webinar. Before we start, some housekeeping rules. If you have any questions, feel free to ask them at any time by typing them in Q&A or clicking the raise hand button, which will be answered by our speakers during panel Q&A sessions. You can also generate subtitles automatically by enabling your closed caption. With this, I would like to begin the webinar with the first poll question for which you have 30 seconds to answer. Can we have the first poll question, please? Does your hospital have a hybrid OR? Yes, no, we plan to have it in the future. No, we do not plan to have any. Can we see the results? So 70% of the audience says that no, but we plan to have it in the future. 25% says that no, we do not plan to have any, and 5% does have a hybrid OR in their hospital. With this, I would like to move on to our second poll question for today. Can we have the poll question, please? Are you familiar with the concept and benefits of hybriding operating room? Option 1, very familiar. Option 2, somewhat familiar. Option 3, not very familiar. Option 4, not at all familiar. Can we have the poll results? So 37% audience says that they're not very familiar, but they have heard about it. 21% are somewhat familiar and very familiar with the concept of hybrid OR, and 21% are not at all familiar. Thank you so much for sharing your answers for the poll question today. With this, I would like to invite the moderator for today's webinar, Dr. Shanmugam Subramanian, who's the Head of Clinical Services and Governance from Prince Court Medical Center. Welcome, Dr. Subramanian.
Hi, Arsh. Thank you so much for that introduction. It's a very interesting initial poll where I think most people who are attending, they don't really know that much about hybrid OR. So it gives me great pleasure in introducing our speakers today. So I'll introduce our first speaker today, Dr. Suksan Kanoksin, Head of Cardiovascular and Thoracic Surgery, Heart Center, Chulabhorn Hospital, Thailand. So I pass the floor to you, Dr. Suksan.
Okay, so thank you, Dr. Shanmugam. Yeah. Good afternoon, colleagues. I would like to introduce myself. I'm Dr. Suksan Kanoksin, and I'm glad you could join me for this late afternoon session. I will share slide first. Okay, so most of the audience they know about the hybrid OR, but they not yet to have this room. So I will share you about my experience for this extraordinary unit. Today I would like to share something that has been transformed our surgical practice, the hybrid operating room. This colorful slide reflects the broadband impact the hybrid OR has had on our work. It brought new dimension to how we approach complex procedure. Over the next 25 minutes, I walked through my first-hand experience with this technology. We will explore how it enhancing our efficiency in the OR and crucially improving outcome for our patients. I have prepared some practical insight and real case scenario that I believe you will find valuable. My goal is to give you a clear picture of how the hybrid OR is shaping the future of surgery. As we begin, I invite you to think about how this technology might apply to your own practice. And we will have time to discuss at the end. Let's get started on this journey. Okay, and the hybrid OR at Jurapon Hospital, we have seen remarkable improvement in clinical efficiency, particularly in cardiothoracic field. Take a look at this image. This is our reality at Jurapon Hospital. What you are seeing is one of our state-of-the-art integrated surgical suite. It looks different from ordinary operating room that we have trained. These hybrid OR are equipped with advanced imaging system that have transformed our surgical capability. We have fixed C-arm, CT scanner, and angiography system all in one room. This means we can perform detailed real-time imaging without moving the patient, which is crucial for complex procedure. But what really set this room apart is their versatility. We have designed them to handle both minimally invasive procedure and complex open surgery in the same space. This flexibility has been a game changer for our cardiovascular and thoracic surgery teams. The impact on our clinical efficiency has been substantial. We are able to seamlessly transition between different phases of procedure, reduce patient transfer, and make critical decisions faster with immediate access to high-quality imaging. As we progress through this presentation, we will share specific examples of how this setup has improved our workflow. And most importantly, patient outcome. But for now, I want you to keep this image in mind. It's the backdrop for the advancement of we will be discussing later. Let's take a quick step back in the time. This image shows our hybrid OR during construction in May 2018. What you see here is the foundation of innovation. From exposed beam to scaffolding, this was the beginning of our journey. It's stark contrast to the cutting-edge facility we just saw. This transformation represents more than just a change in infrastructure. It symbolizes our commitment to advancing surgical care at Jurapon Hospital. As we move through the presentation, keep this before picture in mind. It highlights how far we have come in enhancing our surgical capability and efficiency. Now, let's move forward to see how this construction project evolved into the state-of-the-art hybrid OR we use today. Moving forward to July 2018, just 2 months later, we see significant progress. The structural work is complete and we entering the final stage of the hybrid OR installation. The sliding door you see here are specially designed to maintain a sterile environment while allowing the easy movement of large equipment. At this stage, we were all eager to see the final result, knowing that each element being installed would play a crucial role enhancing our surgical capability. This phase of construction really brought home the scale of the project and the potential impact it would have on our ability to provide cutting-edge care. Let's move on to see how this space transforms into the fully functional OR hybrid we use today. This slide on September 2018, and we see the hybrid OR taking its final shape. The transformation is remarkable. The key feature here is the advanced imaging equipment being installed. You can see the large C-arm is the game changer for our surgical procedure. It allows for real-time, high-quality imaging during operation, significantly enhancing our precise and efficiency. The ceiling mount system that you could notice and the statically placed monitor. These elements are crucial for creating a seamless workflow in the OR. The flooring you see isn't just for anesthetic. It's specially designed to be durable, easy to clean, and conducive to the movement of heavy equipment. At this stage, we were on the brink of a new era in our surgical capability. The excitement among our team was palpable as we anticipate the impact this would have on patient care. In our next slide, you will see the fully operational hybrid OR. This is an operational hybrid OR. Here, we see our team in action at Julapon Hospital, cutting-edge hybrid OR. It's amazing how far medical technology has come. This setup allows our surgeon to perform integrated cardiovascular and thoracic procedure with incredible precision. Notice how seamlessly the imaging equipment integrate with the surgical tools. It's like giving our doctor superpowers. So, why we excited about this hybrid OR? They are game changer for our CVT patient. We can now offer minimally invasive option for procedure that used to require major surgery. The enhanced imaging lets us tackle really complex cases with more confidence. And you know what how the translate to better outcome and faster recovery time for our patients is a win-win situation. You can see the picture. Let's zoom in on those imaging capability. Check out this crystal clear view of the heart and blood vessel. It's like having X-ray vision, but better. Our surgeon can see exactly what they are doing in real time, which means more accurate procedure and less guesswork. Pretty incredible when you think about it. Now, I want to show you the versatility of our imaging technique. On the left, you can see minimal invasive procedure and how precise we can be just a tiny incision over and the lines in an open surgical size. And down below, the detail of CT scan that invulnerable panning of the case before we step in the OR. This technology really let us tailor our approach to each patient unique needs. So this slide shows you the precise diagnosis and planning for complex CVT case. We can use in the TIVA case or in the lung surgery case, with thoracic case. And today we will discuss about minimally invasive procedure in cardiovascular and thoracic surgery. This included TAVI, EVA, or TIVA. This hybrid OR allow us to perform complex surgery with a small incision and less trauma to the patient. You can see this image. We use specialized tools and imaging to navigate through the body with the precision. This approach offers numerous benefits for patient recovery and outcome. So our facility is equipped to handle a wide range of complex cardiovascular and thoracic surgery. This includes procedures such as coronary artery bypass graft, valve surgery, and lung operation. And one of the key advantages of our advanced surgical suite is improve patient safety and outcome. By reducing the need for the patient transfer between imaging suites and operating room, we minimize risk associated with moving critically ill patients. The image on the left shows a traditional CT scanner necessary for many procedures, but on the right, you can see an example of the high-resolution 3D imaging we can now perform in the operating room, streamlining our workflow and improving patient care. And our integrated approach optimizes resource utilization by combining imaging and surgical capability in single room. As you can see in this image, we have access to advanced imaging technology like in the operating suite. This allows for real-time guidance during procedure, enhancing our ability to perform complex surgery with greater precision and efficiency. The benefit of our streamlined workflow extend beyond just efficiency by reducing procedure time and improving our overall process. We are able to lower healthcare costs while maintaining the highest standard of care. The image show an endoscopic view during a minimally invasive procedure. This level of visualization combined with our integrated surgical suite allow us to perform integrated procedure with remarkable precision, further improvement patient outcome. In this case, the patient have a small nodule in lung, so we perform the ICG guide in the operating suite and do the surgery after that. There's no need to transfer the patient from the angio room to the operating room. So this is a shortened time of the surgery. Now we will be a case study. We will show you a case study of the hybrid aortic arch replacement, focusing on the effectiveness of the hybrid operating room in managing complex cardiovascular and thoracic cases. This innovative approach combines advanced imaging with surgical capability, allowing more precise and less invasive procedure. So many papers they are talk about the hybrid OR. So this slide present a key research article from the European Journal of Cardiothoracic Surgery published in 2013. This study explored the hybrid operating room concept for combined diagnostic intervention and surgery in acute type A dissection. The research spanned 7 years period and provide valuable insight into the efficacy of this approach. So moving on, we have a systemic review published in the Journal of Investigative Surgery in 2022. This review summarized application of hybrid operating room across multiple surgical specialties. Key advantages include higher procedure accuracy, shorter operative time, and reduced risk during patient transform. Hybrid OR allow for intraoperative imaging and combine open and endovascular approach. Limitation include high cost and radiation exposure concern. Further efforts are needed to improve cost effectiveness and reduce radiation risk. Overall, hybrid OR show promise for enhancing surgical capability and outcome across specialty through continued evaluation is important as the technology evolves. In this study, comparing resuscitative thoracotomy with labor for aortic occlusion in trauma patients, the labor group had higher rate of neurological intact survival. However, the thoracotomy group had greater shock severity at baseline. Nearly half of labor patients survival to discharge with intact neurological status. While not directly comparable, labor show promise for improving outcome in select trauma patients with performed in a hybrid OR setting. Further research is needed. And about lung nodule localization, like the case I show you on the previous slide. This study examined preoperative localization of small lung nodule in hybrid OR to guide minimal invasive thoracic surgery. Various localization techniques were used, including microcloid, dye, and wire. All lesions were successfully identified and resected. Some minor complications occurred but did not impact surgical outcome. The hybrid OR setting allowed for immediate localization and surgery, avoiding delay and reducing risk associated with patient transport. This approach appears safe and effective for improving minimally invasive lung nodule resection. In trauma, this study that used in trauma hybrid operating room for patients with abdominal pelvic trauma require both surgery and interventional radiology procedure, resulting in shorter procedure time and lower mortality due to exsanguination compared to the conventional approach. Trauma hybrid OR eliminate transit time between operating room and radiology suites, allowing for more rapid hemorrhage control. While overall mortality was similar, trauma hybrid OR show promise for improving outcome in those complex trauma cases. And now we shift here to look at the financial aspect of the hybrid OR. This study published in the International Journal of Health Policy and Management conduct a bottom-up cost and analysis comparing hybrid and conventional operating room. It's crucial to understand this cost as hospitals consider adopting this technology. This study is studied from 5 Dutch hospitals, University Medical Center, Netherlands, in 2022, just 2 years ago. And the cost is showed that conventional suites have cost allowed 9.45 euro per minute, and hybrid operating room cost allow 19.88 euro per minute. The cost is they calculate from total inventory cost plus total constructive cost plus utilization rate and plus total personnel cost. You can see the hybrid OR will have some double cost for conventional OR. So let's examine the broader impact of the hybrid OR. They are revolutionizing cardiovascular and thoracic surgery by enhancing image capability, allow for minimally invasive procedure, and improve patients' outcome. The integration of the advanced imaging in the OR is a game changer for complex surgery. And at the specific case study, we saw how hybrid OR contribute to increase clinical efficiency in cardiovascular thoracic procedure at Julapon Hospital. By streaming workflow and optimizing resource utilization, these advanced OR are making a significant impact on patient care and operational efficiency. Okay, to conclude, I would like to show you a visualization of state-of-the-art hospital facility. This image represents the future of healthcare infrastructure, where advanced technology like hybrid OR are integrated into the hospital design from the ground up. Thank you for your attention. Okay, thank you.
Thank you, Dr. Suksan, for a very informative and intriguing presentation. Probably I don't want to take too much of time. I would like to introduce the next speaker. I would like to introduce Dr. Broaden Titivaporon, Head of Cardiovascular Thoracic Surgery, Charong Krung Pracharak Hospital, Thailand, to give his presentation.
Okay, Dr. Suksan. Okay, thank you, Dr. Shanmugam and Dr. Suksan, for a very nice talk. Good evening, audience and everyone. First of all, I would like to thank you, Hospital Management Asia and Organizing Committee, for inviting me for this opportunity to give a talk on the clinical and operational efficiency with hybrid operating room or hybrid OR. My name is Dr. Broaden Titivaporon from Charoen Pracharak Hospital. Apart from the lecture on the basic and overview hybrid operating room in terms of specification, capacity, and workflow from Dr. Suksan. Two main topics that I will cover today are present shift of cardiac surgery and clinical experience and benefit with hybrid operating theater. In the past, we all used the same approach for all accessible, available open cardiac surgery. But nowadays, gradually shift to less invasive in terms of skin exposure, the extent of surgery. These include bypass surgery on the left upper side of the photo, aortic surgery, and valve surgery on the right lower bottom, or even paradigm shift toward the other approach, for example, transcatheter valve surgery or intervention in aortic valve, mitral valve, or tricuspid valve disease, or combining old school conventional aortic graft surgery with anastomosis, which proved for ages to be the best in terms of durability and lowest rate of reintervention, with technological-driven aortic stent in the complex or unexposed area, for example, distal aortic arch of the greatest extent of severity in type A or aortic aneurysm. We will less observe this extent of surgery this day. The photo revealed open thoracoabdominal aortic surgery. Significant shock guards, as you can see, and difficult during ECMO transport could be observed. This explains how hard we as a surgeon and medical staff have experienced in the past decade. Hybrid could give a choice for maximally invasive surgery to a lower extent of surgery combined with endovascular repair without compromising surgical outcomes by combining cardiovascular OR and cath lab. For example, hybrid arch surgery. Furthermore, it could be a useful tool for minimally invasive procedure, including transvalvular heart surgery. And in specific situation, it also could be a life-saving procedure, which I will highlight later in this presentation. For me, both floor type and ceiling type are fine as a surgeon, as long as the C-arm imaging from PACs and surgical bed are fully synchronized. If we talk about the benefits of hybrid solutions, generally speaking, it would synchronize between surgical procedure and imaging quality for the best outcome. It will improve flexibility and utility after complicated cardiac surgery. It can provide option in very complex cases, especially aortic surgery. 3D or 4D dimensional overlay will improve accuracy and precision in transcatheter valve or endovascular procedures, which require sub-millimeter precision. And for safety reasons, it will reduce radiation exposure and contrast both patient and healthcare provider. Reduction of radioisotope and radio-opaque contrast exposure result in less kidney injury, supported by study from Lille, France group. All cardiac society, including STS, WATS, SCAI, ESC, or EAC, all encourage and endorse using and setting up this hybrid OR. Though this is preferable, it is not a prerequisite, since it is not always available or affordable for each unit. However, the hospital should provide the service with personal and financial support. These are case examples to be the most useful utilization of hybrid OR in cardiac surgery, transcatheter valve procedure, intraoperative angiogram in aortic valve infective endocarditis, minimally invasive cardiac surgery, hybrid coronary revascularization, distal arch aneurysm, bailout PCI in coronary injury during cardiac surgery, aortic dissection with left common carotid artery, left subclavian artery bypass, branched fenestrate EVAR. These are transcatheter procedure benefit from hybrid OR. On the left, transcatheter mitral valve replacement, which nowadays perform around 5 to 10% of mitral valve disease. And the lower bottom is the photo from Canada. Transcatheter aortic valve replacement, on the other hand, nowadays in developed country might reach over 50% of all aortic stenosis disease, while in Asia or Southeast Asia, I believe it's just only around 10% or 15%. Last but not least, on the right side, transcatheter valve intervention, for example, mitral clip, which is procedure using clip to reduce valve regurgitation, resulted in a reduction of heart failure symptom and increased survival. Real-time 3D or CT or 4D CT overlay, both pre-op CT imaging and real-time dynamic volume imaging with moving and beating heart to identify vital structure during the TAVI procedure. In this case, left and right coronary ostia as shown in the picture, to prevent coronary ostia from obstruction after valve implantation and deployment. This is transcatheter valve replacement or TAVI performed when I trained as a cardiac resident. For the first 20 cases, some need to prepare double setup for both intervention and surgical procedures. Some patients require immediate vascular access repair, or even worse, aortic dissection repair. But as I have known for the last 30-40 cases, the lethal complication is scarce. This is the case with infective endocarditis, severe aortic regurgitation with large vegetation that refrains from preoperative coronary cath to avoid embolization. Even preoperative echo reveal good left ventricular ejection fraction and no regional wall motion abnormality. Intraoperative angiogram show a LAD lesion shown in arrow, which require coronary bypass at the same time of cardiac surgery. In a similar setting, infective endocarditis with severe aortic regurgitation, a normal coronary angiogram, in this case, we could opt minute stenotomy and perform aortic valve replacement alone for the sake of faster recovery and less pain and cosmetic result. The trend toward using smaller incision, laparoscopy, robotic surgery, and transcatheter-based intervention to decrease the morbidity of traditional open procedures. Nowadays, whether we have in-house hybrid OR or not, all young surgeons are offering this kind of option for patients without compromising outcome. The surgical setup could be prepared even in the already available operating room from the highlight photo. But it would be easily set up in modern hybrid OR at the top line. The final result, we would barely see the surgical scar from anteroposterior highlight photo of the patient with valve replacement on the right lower on postoperative day 2. The patient has barely seen the scar. In the upcoming robotic surgical assist era, treating triple vessel disease patient has never had this rapid recovery. Combining robotic bypass on left anterior descending and diagonal or obtuse marginal with simultaneously PCI as shown on the left side at the same setting. The patient on the right side is an example of how rapid recovery he experienced on post-op day 1. and the surgical scar is very small, as you can see in the third picture. Another example of the distal arch aneurysm, which as a surgeon we all know is one of the most challenging approach. Since sternotomy is reach only arch disease and thoracotomy at the same time reach only from zone 3 or zone 4. The traditional or classical approach is to perform total arch replacement and leave elephant trunk and perform stage or subsequent open thoracotomy as shown in the upper photo. Luckily, nowadays we have seen this kind of operation shifting toward a hybrid procedure called debranching with TEVR. By moving the aortic arch toward the proximal through sternotomy and performing total arch replacement with TEVR to cover and treat the aneurysm at the same time as shown in the photo. This case was a patient with severe mitral regurgitation with very severe mitral annular calcification, as you can see from the MAC. And we need to perform annular reconstruction, complete annulus. We face difficult weaning from cardiopulmonary bypass and echo reveal regional wall motion abnormality, as shown from the picture. In the past, we might try to bypass at the circumflex area, but this potentially prolong pump and clamp time. Moreover, when we manipulate the heart exposed to the posterior ventricle, this might injure the ventricle from posterior valve strut. The second option, should we put intra-aortic balloon and ECMO to support the heart? This might end up with complication from ECMO. For example, bleeding, stroke, or limb ischemia. Third option, should we transfer the patient to the cath lab according to the regional wall motion, since we predict circumflex artery injury from annular reconstruction? This solution might have a problem during transfer from one suite to another. And we also need ECMO during transfer because the patient cannot wean from the bypass circuit. Or if we have hybrid OR, such as this scenario, we could perform an intraoperative coronary angiogram to define definite diagnosis and treat with the POBA balloon and PCI at once. Another example for subacute type B dissection for complicated and uncomplicated high-risk features. Nowadays, TEVR is mandated to reduce aortic complication and reduce future reintervention, including increased chance of aortic remodeling after TEVR. However, most of the time, intimal tear is located at zone 3, which require more than just TEVR alone. TEVR with neck bypass from zone 1 or zone 2 landing as shown in the clip. And this slide from my colleague showed aortogram from patient with an abdominal aortic aneurysm. We perform aortic aneurysm with fenestrate EVAR, which require precision and accuracy at the same time. I use ChatGPT to forecast the future of cardiac surgery. It's no wonder that hybrid OR could be potentially be part of 3 out of 10 in this slide, providing integral multimodality imaging from angiographic CT, MRI, and overlay into the field. In addition, it will play a vital role in minimally invasive hybrid aortic and transcatheter valve surgery, as mentioned earlier. To conclude, the hybrid OR combine cutting-edge surgery system with X-ray imaging to improve accuracy, complex aortic disease, TAVR, TAVI, which every millimeter count, If a few centimeter or millimeter are misplaced, endoleak-paravalvular leakage might happen. Offer a wide variety of options for a specific disease. For example, distal aortic disease or thoracoabdominal surgery. Ready for plan B backup surgery, such as mitral valve surgery with coronary injury. Angiography diagnostic and treatment will save a life as shown. Rapid recovery. For minimally invasive cardiac surgery or hybrid coronary revascularization with beneficial Lima to LAD bypass. Diagnostic tool and treatment in the same setting as infective endocarditis aortic regurgitation. Intraoperative angiogram could evaluate coronary status before performing surgery. All in all, I hope today's presentation on clinical application and benefit of hybrid OR from my experience will explain and expand how useful and mandatory hybrid settings are in today's surgical care. I finished a presentation with the photo of my case with electrical failure. Try to explain, even if we have hybrid OR or not, or a very ancient fashioned operating theater, we as a medical staff do care and dedicate ourselves to save patients' life. Thank you.
Thank you so much, Dr. Broaden. That was a very interesting and very detailed presentation on how a hybrid OR has improved your cardiac services in your hospital. Without further ado, I'd like to invite Ms. Katsiri Titcom to give us a talk on her topic from Cholabon Hospital.
Okay, thank you, Dr. Sanmukam, and thank you for this opportunity to share my experience. May I share my screen? Okay. Good evening, everyone. Today, I would like to share with you how hybrid operating theater enhance clinical and operational efficiency. Okay, what is the hybrid operating room? The hybrid operating room are the surgical facility that integrate the advanced imaging technology and equipment. This room enable to utilization for advanced imaging technique in conjunction with complex procedure or minimally invasive surgery. The hybrid OR are to enhance surgical precision, reduce operative time, improve procedural efficiency, and ultimately increase patient safety. Now, let's look at the imaging capability in hybrid OR. In hybrid OR, X-ray, C-arm, CT, and MRI technology provide real-time imaging and detailed 3D visualization. This allows for precise navigation of complex anatomy and facilitate minimally invasive procedure. Real-time data sharing enable coordinated care, reduce error, and ensure all team members has access to the same information. In this image, show the model hybrid OR set up with advanced imaging equipment integrated into the surgical space. You can see the large sailing mouse C-arm and other imaging equipment surround the operating table. And now, I will discuss about hybrid OR in modern healthcare from my experience. Hybrid OR are crucial in modern healthcare for 5 key reasons. 1, enhance precision and patient safety. 2, enable minimally invasive procedure. 3, versatility and accommodation of various specialties. for efficiency and elimination of interdepartmental transfer. And last, improve patient outcome and safety. Okay, let's explore either of these in more detail. Enhance precision and patient safety. The integration of real-time image allows for more precise procedure and immediate confirmation result. This reduces the risk complication and the need of revision surgery. In this image, you will see the hybrid OR in action with advanced imaging equipment surrounding the operating table. You can see the real-time image display on screen, allow surgeons to perform procedure with enhanced precision. And next, enable minimally invasive surgery. High quality of imaging facilitate minimally invasive technique, resulting in smaller incision, less trauma to surround tissue, faster recovery, and reduce post-operative pain and scarring. This picture is compare traditional open surgery with the minimally invasive procedure. You can see the difference in the existing size and the use of smaller instrument in minimally invasive approach. About versatility and accommodation of various specialty, the hybrid OR support a wide range of surgical specialty, including cardiovascular, neurosurgical, or vascular surgery. They offer flexibility to adapt to the specific needs of each procedure and encourage multidisciplinary collaboration and innovation. And about efficiency and elimination of interdepartmental transfer. Because of all necessary equipment and personnel in one location, hybrid OR reduce the time spent moving patients between departments. This minimize delay and streamline surgical workflow. In this picture, show that this patient need ECMO but cannot undergo incision. Instead of wheeling the portable X-ray machine into the room, we can utilize the built-in X-ray equipment in hybrid OR. This significantly reduces the time needed for moving equipment, streamline the entire process, and potentially save crucial minutes in emergency situation. And finally, improve patient outcome and safety. The combination of these benefits lead to better overall patient care, reduce risk of complication, faster recovery, and improved quality of life. This enhance of hospital reputation and patient satisfaction. And in the last slide, conclusion, hybrid OR represent the significant advance in modern healthcare. They offer numberless benefits of patients, surgeons, and healthcare facility. As professionals like me, embedding this technology and adapting our skill to work effectively in this advanced environment is essential for staying competitive and providing the highest standard of care. Thank you for your attention.
Thank you, Ms. Katsiri. That was a very short and sweet presentation.
Yeah.
Uh,
Yeah.
but I think it got the gist of what we wanted to get across. I'd like to invite all the panelists to turn on your screens. We'll probably begin with our Q&A session. I invite all the attendees and delegates to put up their questions. Let's try and see how we can best answer them as well. Right. So while everyone is probably keying in or typing in your questions, I actually have a question for Dr. Puwadon. No issues. You can still answer us.
Okay.
Okay, got you there. Fantastic. Dr. Puwadon, do you see a higher utilization of your hybrid OTs, as in your surgical approaches, as opposed to the traditional approaches? Because I think earlier in your slide, you did indicate
Yeah.
that it has that. So based on your experience in your hospital, since you started using the hybrid OR, have you noticed a reduction in your traditional approaches?
Yeah, I mean, in general, I mean, nowadays, the traditional approach for the cardiac surgery has been reducing. I mean, it's still the vast majority, but it's on the trend of reduction of the sternotomy due to valve replacement or valve repair through the sternotomy. Nowadays, I believe that in Thailand, we would say 20 or 30% of valve surgery performed by smaller incision, or even shift towards the transcatheter valve, as I mentioned earlier. And for the bypass also and aortic surgery also, I would say 20% of reduction of the traditional approach.
That's fantastic. How about you, Dr. Suksan? In your experience, how do you see the utilization of your traditional versus the hybrid approaches? Dr. Suksan, sorry, I think you're on mute.
Sorry, I forgot to open the microphone. So, I'm agree with Dr. Puwadon, but in nowadays, in our field of the cardiothoracic surgery, most of the hospital in Thailand now, they are prefer to do the smaller incision in the cardiac surgery, also in the thoracic surgery also. And for example, that most of us, you do the videoscopic assist thoracic surgeries instead of the open thoracotomy. Most of the young surgeons, they are graduated from the training. Most of them, they prefer of this technique. And if we combine the video assist thoracoscopic surgery in the hybrid OR, for example, that if the patient have a small nodule, that we need to localization that, because in the small incision we cannot put in our finger to palpate the nodule, or we cannot identify where is the nodule in the lung. So if we use the guide, I mean that some localization that we use is the indocyanine green injection. That combined with the CT scan in the hybrid OR, we can do the localization. Then after that, we can perform the surgery after that. That is reduce the time and reduce the transfer patient from the angio suite to the operation suite. If we reduce the time, the benefit will occur to the patient, and we can reduce the cost, reduce the complication, anything. And in the cardiac surgery also, we prefer to the small incision. So if we do the small incision, we need some angiogram to find out and make the minimal invasive procedure. Like if we do endovascular surgery like this. Nowadays, we do the endovascular surgery a lot in Thailand, in the aortic surgery. So this is the benefits of the hybrid OR.
So both Dr. Puwadon and Dr. Suksan, both of you all in your current practice, in your current hospitals where you all have hybrid OTs, you do see an increased utilization of it as well. So that does help your patients. Yes.
For me, we use the hybrid OR ordinarily. We use every day.
Fantastic. All right, that sounds fantastic. So another question, probably this one is to Dr. Puwadon, because you pointed towards this during our presentation. You had touched upon the future of cardiothoracic surgery and how it ties in with robotic surgery. So how do you see robotic surgery working in symphony together with the hybrid ORs? I mean, you see, as it is, the robotic system is already large, and hybrid OR is also large. So operationally, probably you could give us some idea of how that's going to look like.
For me personally, I haven't seen any operating theater combining both robotic and both hybrid OR at the same place. Because of the size of the console, we have normally we have two console, and the robot also the other part. And if we combine, sometime it might need at least 14 by 14 or 12 by 12 meters of the size of the room. Sometimes it's too big. And if it's that big, the CR will not cover all area of the table. I've never seen, but it would be beneficial if we could. But I think from the benefit of the hybrid, from the place that I trained as a fellow in Canada, I just come back for a few months. They have hybrid OR next to the robotic OR.
I see. Okay, so that makes a bit more sense, because I was trying to understand that earlier as how you would probably work it together, but definitely then that makes a bit more sense where you have it in side-by-side ORs. Dr. Suksan, probably, do you have anything to add to that?
Yes, I think the robotic is a new era. Yeah, in my hospital also we will have the robotic room in the next month. In the next few months we will have the robotic room in.
All right, and so in your hospital, have you all planned it where the robotic room is side by side to the hybrid OR?
Yes, we have the two hybrid room and one robotic room nearby.
That's fantastic. That's fantastic.
Yeah, I would visit one day, Dr. Suksan.
Sure. We appreciate that.
All right. So I think we got some questions from the floor. Not sure to what extent our panelists would be able to address this. But do you have any guidelines or any sources which our delegates can refer to if they would like to do something similar to start designing or looking at having a hybrid OR in their setting?
Okay. First, I would say we have two options. We build from the scratch, or we rebuild, or rebuild from the old ancient OR. But we have to at least pass the minimal requirement of the hybrid OR. For example, the height from the floor to the ceiling should be roughly more than 3 or 310 meters, and the load capacity of the floor should be more than 400-500 kilograms per meter square. Or we still have, at least we need the size of the room more than 6.6 or 8.8 would be best for the hybrid. And we also, if ask the technician, we also need the room for the tech room, and we also need the room for the control room. Yeah, that what I. But if you want one, you could ask the company, because some detail might different from each others. For example, Siemens, Philips, or Hiram, Tomb, or whatever. Philips, yeah. Marke, or the other one, yeah. What do you think, Dr. Suksan?
Yes, I agree with you. And maybe the another issue we should be concerned about the invisible dangers about the hybrid OR. And do you think this issue we should be aware about the radiation? The radiation in the hybrid OR is very dangerous, because if we not good protection someday.
Yeah, as I know, if we renovate the old room, we need at least a very thin but very high quality of the lead that to protect
protection.
Yeah, but if we build the another one, we could build a thick a thick wall, or we could put some
Yes.
thin leads
Yes.
inside at the same
Yes.
time. Yeah, we have an option.
Yeah. Yes.
All right. Okay, so probably this question is to Dr. Suksan. I'll start with you first. In your hospital, because you said you have 2 hybrid ORs and you're upcoming robotic OR as well. Other than the cardiothoracic surgeons, do anyone else use these ORs as well? Any of your other specialties without the cardiothoracic surgeon being there? I mean, because I think some of our attendees are also from non-cardiothoracic areas, so they would also want to understand whether this investment can also be utilized for other specialties, because I
Yes.
think
Yes.
in your
Yeah.
presentation you did indicate something along those lines.
Yes. Yes. This is our policy in my hospital that every operating room we can share with the another department. And for example, we have the vascular surgery, orthopedics department, and gynecological department. They can use the hybrid OR and robotic OR as well, and we use as a team, and we are sharing the schedule which for the operative time, and so we must to use the room for effective, and so we can use every day, so every department can use it.
Fantastic, that's nice. How about yourself, Dr. Poran? In your hospital, do
Yeah,
anyone
but
use the hybrid ORs
so
using the facility?
yeah, so hybrid OR work 100% as a normal OR. So everyone can use. I mean, even you don't use a very high facility for imaging, you can use as to do the appendectomy. That is the key. So anyone can use it, but the department that use it for a very be the most benefit would be cardiothoracic, thoracic, vascular, neurovascular, radio interventionist. For example, we drain something from the liver or whatsoever, or I would say orthopedist sometime, yeah, urologist sometime.
All right. I mean, because
And cardiologists can use it. Yeah, cardiologists can use it also at the same time to do the
so
angiogram
I
or
think
to do the
looking,
TAVI.
I think looking at it, definitely a lot of specialties can use it, because hybrid OR generally can function as how a C-arm would function in a traditional OR as well.
Yeah.
So installing a hybrid OR, definitely, yes, cost is higher, but for a center which has limited resources, not much space, and looking at expanding into hybrid OR, at least you don't lose out on that. You probably don't have to invest in another C-arm. Then I guess you could use that OT as a C-arm OT as well. That would be something that's interesting as well. So it gives some benefit to hospital admin side, I guess, to justify the cost as well. Because I think like what Dr. Suksan shared earlier, the cost between a hybrid OR and a traditional OR probably is about per minute was about 10 euros
Yes.
difference, I think, right?
Yes.
So that's quite a significant investment. So most of the hospitals would want to optimize it to the best that they could.
Yes. And the another thing I wanted to mention about this, in the hybrid OR, we need some technician, the keen technician that are familiar with this very complex equipment like this, like the angiogram or CT scanner or C-arm in the hybrid OR. So this technician should be specialized, like Miss Kesley, she specialized in this equipment, and the technician can help doctor a lot to produce the image that we need. So why we have this technician to take care of this hybrid OR.
Interesting. So Dr. Suksan, probably to build on that, in your experience when you all set up your hybrid OR in your hospital, what was the learning curve like for the rest of the team? I'm sure, of course, the surgeons would have gone for some attachment overseas, but what about the the other members, like Katsiri and also your other team members in the hospital? How was the learning curve like, and how long did it take before they were comfortable with the systems?
Yes, thank you for your question. The learning curve for this hybrid OR is not so difficult. It's fortunately that is very short learning curve for this. For our team, for my team, take time around 3 months. We can perform the every procedure smoothly.
Nice.
About 3 months.
Katsiri, probably you would want to weigh in on that as to how your experience was when you first got introduced to the hybrid, or how did you go about it as a non-surgeon in this case?
About in my experience, the first time the specialist of the equipment to teach and explain about the function, about the what to concern about the C-arm, and we have a workshop for move, for control, for set the resolution of image to make everything is smooth. And then we will to check it's okay. I can do by myself, and so doctor is allowed to do the surgery, so the procedures. Okay.
That's interesting. I mean, that's interesting. Yeah.
The important is you must to suggest for the specialist to experience with that equipment is very important.
Okay. That's interesting. Yeah, I think I would agree with you there, definitely, Katsiri. I mean, the surgeon or the doctor who's operating it has to be experienced with it. I think Dr. Puodan would agree on that as well with his experience, like what he was explaining earlier, how at the initial stages, how it was in the surgeries, then as you get more exposed to it, how your surgeries then change a bit.
I believe that in the very, very beginning, in every center, the one from the company like Philips or Siemens or GE or Canon Toshiba will be available for you at all time at the very first, like for 3-4 months. I believe it's always be there.
All right, so that's something interesting. So I hope our guests would take that into account when you are engaging with the vendors, to ensure you get that support so that you are secured throughout the entire process, from what our colleagues have just shared with us as well. I think there's a question from the floor on, can we use radiation sterilization for hybrid ORs, for example, UV ray sterilization? I'm not sure. I think that
I don't get it.
I think where they're getting at is, how would you sterilize the OT? There are some some vendors who use UV sterilization for their OT. So probably the question is whether such UV sterilization would affect the hybrid OR. But I'm not sure whether our team here would be able to dive into that technical details. If anyone would like to say anything, you can. Don't think this would be the right platform to discuss this. We have cardiothoracic surgeons and we have perfusionists here. We're not going to be able to give you too much details into it. Again, I think for this question, it would very much depend on the vendor. You would need to go back to the vendor because you're buying it from them, and you got to make sure that the warranty period, everything is okay. So probably that would be the best source. Dr. Suksan, anything to add to that?
Yes, in hybrid OR, they don't need any special sterilization. They need only ordinary sterilization, like a traditional OR, because we built this room in there. We pick up the material that to resistant to the microbacterium as well, and we can use the ordinary antiseptic or any kind of sterilization that we use in the traditional. There is no need to any special sterilization. If you use the UV lay in traditional OR, you can use in the hybrid OR as well. Yeah.
All right.
But we need the class, the sterilization class.
Yeah, 10,000.
Yeah. Yes.
Yeah. All right. So, do you all have any other questions that you would like to discuss about, where you would like to give a bit more information to our delegates and the viewers online regarding hybrid OR and its functionality per se?
Yes, and in your hybrid OR, I just want to make to tell that everyone should be concerned again about the radiation protection, because this is very important. But most of us they look across this. We're not concerned about this, and we need to certify of the radiation protection from the National Nuclear Organization to confirm that this room is in the standard of the radiation protection.
I think I was in Bangkok recently in March for HAI convention. So I did hear about your occupational safety standards in Thailand, where it's quite stringent and it's quite similar to what it is in Malaysia as well. I think
Yes.
a lot of requirements are there when you're building a hybrid OR to ensure that it's safe for the user, the operator, and the patient as well.
Yes.
I believe most hospitals have that, and there are a lot of guidelines available online on this as well, in terms of what are the requirements for radiation safety in an OR per se. So definitely our delegates will have to look into it. But Dr. Suksan, Dr. Puwadon, Dr. Kitsedi, I think you all have had a lot of experience with hybrid OR, definitely. But from the time that you started using hybrid ORs to where it is today, were there any pitfalls or anything that you could share with our delegates to ensure that they look out for them when they are looking at developing a hybrid OR, as in something that was overlooked that other people can take into account besides the radiation safety part of it?
Yes, the another issue that should be very big concern. I think you should have big concern about this, because the hybrid OR is a very high cost investment. In our hospital, the cost investment in this room, only this room equipped with the angio suite, is allows 70 million baht. 70 million baht. So it's a lot of money. You should aware that you put in some very high cost inside the structure of the building. So the important is the building. The building should protect your very high cost equipment. So the first one who want to build up the hybrid OR, you should select the building that is strong enough to protect your high cost. Protect from what? Protect from land, any earthquake like this, and raining or water or leakage of the water inside the room like this, or any electrical power disruption. It can make your very high cost to the zero.
Agreed, definitely.
Ruin your hybrid OR.
Right.
Yes,
Should we
this is
build a
very
new building?
important.
Should we build a new building for that?
No need to build up a new building, but you make sure that your building is strong enough, can protect your very high cost.
Yeah,
This is very, very important pitfall that I think the most of administrators, they look over this. They some of the administrators, they concerned about it, but most of the administrators or who need the hybrid OR don't concern about this, about the building.
I think I would agree with you, because I did come across previously some hospitals where they have invested in very high cost items but end up getting ruined because of leakages or some form of water damage. So I have come across that as well. I would agree with you, Dr. Suksan, in that sense. when you're looking at investing in such high cost items, high ticket items for that matter, you've got to ensure that everything is well accounted for, and all risks are assessed and necessary mitigations are already in place for those kind of situations, so that you protect your investment and you also ensure that that service is available for your patients for the sake of the patient safety part of things, as we were discussing earlier. Dr. Broaden, is there anything else you'd like to add on to that, or Ms. Kitsiri?
Not at that point, but I would say you will, I mean, like for the provider, for the doctor or the administrator level, you will never know or realize how important of the hybrid OR until you or your relatives is in the OR and the doctor needs it during the case.
Agreed, definitely. All right, so looking at, we don't have any other further questions. Probably I would want to end this. I would like to thank all of our panel of speakers. Very informative sessions that you all have, what you've presented and what we've discussed subsequently. If there are any further questions, please do send them over. We would try to address them later on. I'd like to say thank you so much for your evening, for your time, all our panelists. I know all of you all are very busy and very occupied, but thank you for making some time for our webinar guests, and thank you so much. Ash, I think I'll pass the floor back on to you. Thank you so much.
Thank you.
Thank
Well,
you.
thank you so much, Kitsiri, Dr. Shanmugam, Dr. Suksan, and Dr. Broaden for making this webinar a success. It wouldn't have been possible without all of you. And it was really great to learn the benefits of having a hybrid OR in the hospitals. With this, we have come towards the end of the webinar. And before we close, we would like to go for the last poll for the evening. Can we have the poll, please? After learning about the benefits of a hybrid OR today, how many of you would consider going back to your hospitals to pitch it to your management? Will you look into pitching this month? Will you have other priorities and pitch it within a year? Whether you're convinced that it's not a must-have, and whether you're not in position to pitch that.
I would like to see the answer.
Can we see the results, please?
Yeah, let's see. Oh,
So 42%
roughly
says
70%.
that, yeah. So 70% say like, whether they will pitch it this month or they will pitch it this year. So that's like, a good percentage. And with this, we have come to the end of the webinar, and do check the hospital management Asia space for upcoming webinars, and do join us for HMA Bali. Thank you for joining us today. Have a great evening.
Thank you. Bye-bye.
Thank you.
Thank you. Bye-bye.